You're live, sir.
Yeah. Thank you. I'll just start the webinar. Thanks for all the attendees for the Indo-Arab webinar. I think one of its kind. We have number of world-renowned faculty sitting with us together, starting with two international faculties. We have Dr. Saeed Al Thani, who is an eminent and renowned orthopedic surgeon, as well as a shoulder and arthroscopy consultant, not only known in the soils of Middle East, but across the globe with over more than 25 years of experience. He was the chairperson of AVO Middle East segment. He was the immediate past president of Emirates Orthopaedic Society. And he needs no introduction as far. Thank you, Saeed sir, for accepting our invitation. Thank you.
The honor is mine. I'm very pleased to join you guys.
Thank you. The other international faculty, we have Dr. Usama with us, who is a seasoned arthroscopy and shoulder consultant working with Medcare Hospital, one of the finest hospitals in Dubai and throughout the Middle East. He is an active academician and also involved with the AVO Trauma Educational Society and an active member of the Dubai Shoulder Society, and a very, very kind-hearted person who also needs no introduction. Thank you, Dr. Usama, for joining us this academic webinar.
Thank you very much, Raj. Thank you for the invitation. The honor is mine. Thank you very much, guys.
Thank you. And the session will be chaired by none other than Dr. I.P.S. Oberoi, who is the current president of Indian Arthroscopic Society. He does not any words or require any introduction from myself. He's a renowned surgeon, not only in the Indian soils, across the globe. Despite being one of the earliest surgeons to start arthroscopy in India, he's also a mentor to thousands of young arthroscopic surgeons, including myself, and one of the greatest academicians and talented person that I would have ever met. Thank you, sir. Thanks for joining us and for chairing the session.
Thank you for these kind words. Thank you.
Thank you. We have Dr. Thirumalaisamy on our expert panel, who is one of the renowned orthopedic surgeon. He is a consultant with one of the best hospital in South India, KMCH, and he is a great academician and an active member of the AVO teaching faculty. He is our current president of the Tamil Nadu State Orthopaedic Association. Thank you, sir, for joining us. Thank you. And along with us, we have Dr. Atul, who is our beloved Secretary of Indian Arthroscopic Association. Thank you, sir, for joining us. And two national faculties, we have Dr. Senthil Velan, who is a clinical lead and chief in one of the renowned institutions in India, the Miyot Hospitals. He's been trained entirely in UK, and one of the pioneer. He has his own he was one of the part of the inventing team associated with the Trans-Osseous Repair ZIGS, and a very good friend of mine. Thank you, Dr. Senthil, for being on board.
Thank you. Thank you very much for inviting, Karthik. Thank you.
Thank you. And last, myself, Dr. Karthik, who is a shoulder consultant in Coimbatore, South India. Thank you. I hand it over to Dr. I.P.S. Oberoi to chair the session, please.
Thank you, Karthik. I think you have actually arranged a host of renowned national and international faculty for a topic which is a hot topic these days, and it is shoulder instability. I'm quite impressed to see all the topics, because we start with the clinical decision making, which is very, very important. I think 5 tips which you are going to give is going to give an insight into how to decide which patient would need what kind of procedure. Followed by Dr. Usama, who is going to talk about Bankart Repair. Arthroscopic Bankart Repair is something which has been now established procedure for shoulder instability. However, the techniques of doing Bankart are different from one surgeon to another surgeon. The type of anchors being used, from knotted to knotless anchors, and different techniques. I think it would be quite interesting for us to hear from Dr. Usama how actually he tackles instability while doing arthroscopy, especially the back. Saeed Al Thani does not need any attention. He's a renowned shoulder surgeon and arthroscopy guy. And talking about Remplissage, I think from him is very, very encouraging, because Remplissage is something, a procedure which is a very useful procedure. However, still a lot of surgeons are underusing it. They are not actually understanding the indications of Remplissage, when exactly to do it, how to do it, and choosing the right patients to do it. I think if he is going to cover those topics, I think it will be much beneficial for all the delegates. And Senthil, our friend from Neot Hospital, Chennai, is going to talk about mini open Latarjet. I think Latarjet should be an armamentarium of every shoulder instability surgery. And Senthil has excellent videos about his technique, and I think he's edited those videos as well. So I am quite happy to see his videos once again in this webinar. Karthik, thank you for organizing this webinar. We have our co-chairs here, Dr. Thirumalaisamy. I think he is a guy who does not need any introduction. He's president of TNOA. And I think it will be an excellent discussions here. Thank you, Dr. Atul, for joining in. Atul has been spearheading orthopedic education in India, especially last couple of months in COVID times. It has been amazing how Indian Orthopedic Association has actually done a lot of academic online work. So let us go directly to you, Karthik, starting with the academic deliberations. Your presentation on the clinical decision makings in shoulder instability. You said you are going to talk about some 5 tips about it. So let us hear from you. And then in between, we can have maybe 1 or 2 questions, which are burning questions, but let us keep the discussions at the end of the session. Hopefully this is good with all the panelists here and the faculty. Perfect. So I think Karthik, if you can share your screen and then we can go ahead.
Thank you, sir. Thank you for the kind words. I'll do the screen. Is my screen clear?
Yeah, it's pretty clear.
Yeah, thank you. So starting with my talk today will be on the decision-making protocol for anterior shoulder instability. As far as this academic webinar is concerned, I do not have any disclosures. Before going to the talk per se, let me put across a couple of my cases which fit into on either sides of the spectrum. The case 1 would be a 19-year-old male, anterior instability last 3 years, recreational sports, no laxity, and the key features with a bone loss of 11% and an on-track lesion. Let's keep this in mind. Case 2, a 27-year-old male, right shoulder instability, 5 years. On the contrast, he's a professional contact sports athlete, no laxity. Now looking at the bone loss, significant bone loss of 28% and an off-track lesion. Let's keep this 2 in mind. And at the end of the talk, I'll put across how my decision-making protocol and the surgical videos. Now going to the objectives of this talk, I would like the audience to be clear on the concept of glenoid tracking, have the ability to assess intricately on the characteristics of Bankart's lesion, take a closer look on the details of Hill-Sachs, look the patient as a whole, and most importantly, to customize the decision-making protocol with patient regards. Not but last the least, we need at least one good scoring system to use in our clinical practice. Before jumping on to the concept of glenoid tracking, let me have a few words on the bipolar lesion that we talk about every time. Now, the bipolar lesion is nothing but the lesion that happens on the humerus and on the glenoid, combinedly constituting to shoulder instability. This is a beautiful animatory video, which is self-explanatory, courtesy Dr. Giovanni. Now, looking into the literature, we understand the prevalence of bipolar lesion to be as close to 81 to 86%, which constitute that every 8 out of 10 patients in our clinic with shoulder instability do have a significant bipolar lesion and needs to be attended and thought about before deciding on the treatment protocol. Starting with the first pearl, we would like to start looking at glenoid tracking. Glenoid tracking is nothing but the dynamic relationship between the two lesions on the humerus and the glenoid, and their combined effect, which contributes to the instability. Now, this was brought about by Giovanni et al. And Steve Bankart. Theoretically, it is nothing but the articulating area between the glenoid and the humeral head when the arm is put in the functional position of 90 degrees abduction and external rotation. It constitutes to around 84th percentile of the glenoid width from the cadaveric study done by Yamamoto and SG. Now, we all know cadavers are a whole lot different when we look at humans. So the study was extrapolated along with Omari et al. To look at living individuals, and the magic number is 83 percentile of the glenoid width. Now, to remember for our clinical practice, the digit 83 percentile of the glenoid width is what we need to remember. Next, the entire concept of tracking is to categorize the Hill-Sachs lesion into on-track and off-track lesion. Now, these are extremely useful animations from Dr. Giovanni. The one on the left portrays an on-track lesion. Let me play that. Now, on-track lesion is one where the Hill-Sachs does not engage after a good Bankart's repair, which means it need not be addressed separately after a simple Bankart's repair. Now, let me play a video on the right, which illustrates a Hill-Sachs lesion that still engages after a good Bankart's repair. Now, which means this needs to be attended separately and to be given importance. Now, this off-track lesion can be because of two types of Hill-Sachs, either a huge mediolateral extending Hill-Sachs or a very medially located and a deep Hill-Sachs. Keeping in mind, let's put the concept of glenoid tracking into clinical practice, for which it's been proven beyond doubt in literature that 3D CT reconstruction when on-face imaging of the glenoid is the best till date. I agree there are a lot of controversies to get the true on-face images. There are being computer softwares developed for that, but till date we can utilize these most suitable on-face 3D imaging. Now, the method of calculation, linear or area method or the PICO method, slightly more accurate, but the problem is that we need a special software, and with regard to reproducibility, the linear method scores across. So in my practice, I stick to the linear method. Having chosen this, we need to measure the pre-glenoid width or the pre-injury level of glenoid width, for which we have two methods, either using the best fit circle method on the injured shoulder or utilizing the contralateral shoulder. We had come across with a study which was published in the late part of 2019, JBJS, where we compared both the method and found that the contralateral method is far more reliable and accurate in assessing the pre-injury glenoid width. Now, this has an only exception in cases of bilateral shoulder pathology, or else I stick to the contralateral shoulder method. Having known that, these two diagrams give us a quick depiction of how do we calculate. The one on the left shows the glenoid. Now, 83rd percentile of the pre-injury glenoid width, which is taken from the normal shoulder or the contralateral shoulder, gives us the glenoid tracking, from which we need to subtract the width of the glenoid bone loss to arrive at what is known as effective glenoid track. Now, after calculating it, we need to look at the Hill-Sachs interval. It's nothing but the addition of the mediolateral largest dimension of the Hill-Sachs with the bony bridge between the Hill-Sachs and the cuff attachment. Now, to make it simple, if the Hill-Sachs interval is smaller in value than the effective glenoid tracking, it means the lesion is on track and need not worry. If the Hill-Sachs interval is larger than the glenoid track effective value, which means it's an engaging Hill-Sachs and need to be looked at. Now, the second pearl is the glenoid bone loss, we have three different subcategories for that. First one, we need to define what's a critical or a definitive bone loss beyond which a soft tissue repair had no use. It's been proved beyond value in literature that anything beyond or equal to 25% of the glenoid width requires a bony block procedure. Whenever we have a critical bone loss, we do have something called as a subcritical bone loss. Now, when we talk about subcritical, only two papers or works come across to us. One is work by Saha et al. Group, which gives us a value of 13.5 to 20% as a subcritical bone loss value, and the work by Emirates, which gives us a value of 17% to 25% as the subcritical bone value. Now, how can there be two bone subcritical values? Now, for that, when we take a closer look on these ones, the one or the lower range subcritical value was executed or studied in militant population, which is a higher demand people, which is equivalent to contact sports athletes. They show a lesser tolerance or a low tolerance threshold for the bone loss. And compared to the study by Emirates, which was conducted in the general population, which showed a slightly more tolerance with regard to bone loss and Bankart Repair. Now, how do we have a take-home message? Now, the 2019 ISACOS meeting had finalized there are two subgroups of bone loss, 13.5 to 17, which do not have a frank recurrence of instability, but tend to have a lower functional score if gone ahead only with soft tissue repair. And the other subgroup, the 17 to 25 percentile bone loss, tend to have a higher recurrence rate in high demand patient and also a lower functional score. Now that rings the bells on our mind. Now the third point in the glenoid is looking at what type of bone loss. Are we looking at a fragment still there? Yes, there can be 50% of the lesions do have a bony fragment, and interestingly 55 to 60% of the fragment belongs to the medium or large category, which can be repaired. Now that is a point to be kept in mind. Now what do we have a take-home message? Smaller fragments do have higher recurrence, especially the fragment size less than 5%. Now the success of bony repair depends on two things. One is the size of reconstructed glenoid. We may not be able to reconstruct to the original size, but to its equivalence is important. And this is one surgery that depends on the surgical skill. Now the third pearl is taking a closer look onto the Hill-Sachs. Now in Hill-Sachs, we all know we split them across into on-track and off-track lesion. Now, do all on-track lesions behave the same? Now this question is beautifully answered by the research work by an Emirates group, which was published in, I think, the middle of 2019, which dissects the on-track Hill-Sachs into two categories, the centrally tracking lesions and the peripheral tracking lesions. Now, to make it simple, one can have a look at the two figures on the right side. It is nothing to extrapolate the effective glenoid track over the Hill-Sachs lesion from the cuff attachment, and the tracking is divided into 4 zones: 0 to 25, 25 to 50, 50 to 75, and 75 to 100. Any Hill-Sachs that is huge extending to the zone 4 or small but deep and medialized existing in the zone 4 beyond 75th percentile is considered as a peripheral track Hill-Sachs, and this is said to have a significantly poor shoulder outcome, if not frank recurrence. Now this needs to be kept in mind, especially with regard to patient factors. Now the fourth pearl that I would like to talk about or stress on the importance is the patient factors. Because of all the factors, this is most important. No patient is the same, goes true even for shoulder surgery. The important factors that we consider are age, 20 or plus, type of sports, contact or non-contact, professional or recreational sports, and last but not the least, a deeper look into hyperlaxity, which can be a generalized or localized, to be kept in mind before putting our knives on hand. We need to have a shoulder scoring system. I follow on with the GTIMS, which is the Glenoid Tracking Instability Management score put forth by Giovanni. Now, this is similar to the gold standard of IS score, except for the fact it takes into account the on-track and off-track lesion, which was not incorporated in the ISIS, and ISIS utilized the conventional radiograph. Now, this score stands with this similar fashion as ISIS. Any score of 4 or more falls towards a bony block procedure. Now, it's made very clear if you simply or if you blindly follow the scoring system for a score of 4 or more, which means all the off-track lesions have to be converted into a bony block procedure. That's why I keep repeating, in a globalized fashion, not one point is important. Seeing the patient and all the factors are important for making a decision. Now we have all the concepts in front of us, makes it more confusing. So we need to have an algorithm which is simple to put into practice. Now to form an algorithm, I would like to categorize the shoulder instability groups into two types. A definitive category wherein we have a clear-cut evidence-based treatment protocol, and a gray zone category which is also based on the gray hair of the surgeon and expertise. Now, there are 4 groups on the definitive category: a bone loss with less than 13.5, centrally tracking lesion, and an off-track lesion. Similarly, bone loss more than 25%, off-track and centrally tracking lesion. Now, the decision protocol is quite clear. For a bone loss 13.5 and less and a central tracking lesion, a simple and clear-cut arthro Bankarts would do the work and nothing else is needed. For a bone loss of less than 13.5 but an off-track lesion, an addition of Remplissage does the work. A bone loss of 25 plus category and a central track lesion is a categorical method for bony block procedure. And a similar bone loss with an off-track might as well require a Remplissage. Now, these 4 categories, we have a clear-cut, a literature-based decision. Now, what is this preoperative assessment? There is a small subset of patient where we tend to have a huge bone loss beyond 30 to 40% of bone loss, wherein we always like to have a preoperative assessment of the postoperative reconstructable glenoid. So now this was the concept brought about by Peter Millett of Minnesota and Moog, who started utilizing or adding the effective glenoid track in the injured side with the bony block width, which calculates the postoperative reconstructable glenoid track, which could be utilized as a tool of measure for patients with glenoid track more than 25% and off-track lesions, where important decisions wherein a straightforward Latarjet or congruent, non-congruent, or maybe a different bony block like a iliac crust and so forth might be required. Now let's see what are the factors in the gray zone or the intermediate zone. We have 3 balls in our basket: bone loss 13.5 to 25, peripheral tracking Hill-Sachs, and the bony fragment. I would like to utilize a small flow chart which shows us the decision making is based on the 4 images on the 4 corners of the slide, starting from age, the profession, type of sport, and patient factors. Now, regarding the bone loss subcategories, we saw that there are 2 categories, 13.5 to 17 and 17 to 25. Now, the threshold level is entirely dependent on the patient demand. For example, for a patient, contact sport athlete patient, even with a bone loss of 14%, I would directly jump to a Latarjet. But for a patient and an athlete, non-contact, who requires more of proprioception in the shoulder, like a tennis player with a 13% or 14% bone loss and a Hill-Sachs, I might still prefer an anatomic Bankart Repair, which still adds on to its proprioception. Now, Hill-Sachs, peripherally tracking Hill-Sachs needs to be kept in mind and needs to be addressed with a Remplissage based on the patient demand. Bony fragment, it's always to be kept in mind. Try as much as possible to repair the bony fragment until unless it's too small or not viable to repair. So basically, the subcritical zone requires a multifactorial and an expertise approach. That would end my talk per se. Looking at the cases which were discussed at the first, case one was not a classical sports guy with a small bone loss and an on track. I had gone with a, yeah, this is my video, a Bankart's lesion, pretty much the clock face sizes, with a classical arthroscopic Bankart's repair. Now case two, huge Hill-Sachs, off-track Hill-Sachs and a huge bone loss. I jumped towards a Latarjet. In this case, I had gone ahead with a classic mini open Latarjet. Now the conflict comes whether it's mini open or arthro Latarjet. Having done both, I think what is really important is not mini open or arthroscopic, but applying the principles and the ticks and trips which my colleague in the future sessions will be talking about. So I do not want to waste time on these videos. Let me go to the last point of the video where this is the kind of arc we would like to reconstruct. Now the third case, a little bit on the gray zone, 31 years, female, tennis player, shoulder instability, 15% bony fragment, off track. Let me go to the video. This was the bony fragment. Keeping that in pause, I went ahead with the Remplissage, put a couple of my anchors there, kept it in a there, and went ahead completing my bony Bankart's repair. I follow the bony bridge technique by Peter Millett, which nicely encases the bony fragment with medial and lateral anchors. And then once I'm done with it, I go tying my Remplissage anchors where I use the double loose technique through a single cannula. I do not go to the subacromial space looking for it. And this is the kind of placement of the infraspinatus tendon I like to have across. So the take-home messages are always keep in mind of a bipolar lesion. Glenoid tracking is a practical and time-tested concept. Subcritical and peripheral tracking lesions need to be aware. Out-of-the-box cases needs out-of-the-box thinking. And keep in mind the 5 pearls which can stand by you at the time of decision making. Last but not the least, I always like the concept of shoulder crane put forth by Greg Bain from Flinders, who talks about the shoulder not as a single joint, but the entire upper limb and also the scapulothoracic movement, which means a tunnel vision of only shoulder pathology might put us to trouble, wherein the patient might have concomitant scapular kinesia and other issues. Thank you.
Thank you, Karthik. Wonderful presentation, especially you talking about 5 pearls. I think decision making is pretty important when we start operating on shoulder instability. You have actually covered almost all the points which are controversial. People talk about it, especially suboptimal or subcritical bone loss. You have also talked about the age of patient, the occupation, how it is very, very important when we are talking about a subcritical bone loss. You talked about the glenoid bone loss, both quantification and then how exactly you combine the glenoid bone loss and the on-track and off-track lesions. And then your algorithm, your slide where it actually made the 4 algorithms depending upon the bone loss and off-track gives a very good opinion about when we start making decision about the bone loss. What is also important, because it's evolving these days, we still have got no answers about the capsular tissue. We still don't know how the capsule tissue. Sometimes you have a very small bony Bankart or a Bankart, but the capsule is not great. So in those cases, again, we still need to develop some protocols. We still don't have protocols about the glenoid, the bony Bankart size. It's not clear in literature how exactly to deal when the loss of the bone fragment is a small or a moderate or a large bone fragment, or how the results are there. And also issue regarding the depth of the Hill-Sachs lesion. We talk about location of Hill-Sachs, we talk about the extent of a Hill-Sachs, but we don't talk about the depth of the Hill-Sachs, which is also quite critical. So I think a lot of things are evolving, and your presentation actually solved a lot of mysteries regarding decision making. We'll have some questions at the end of the session as well, but I think I would invite Dr. Usama Saleh to share his screen and talk about the gold standard method of right now treating shoulder instability, especially in absence of remarkable bone loss, that is arthroscopic Bankart repair. His tips, his tricks, how exactly he does it. Dr. Usama, please.
Thank you very much, Dr. Oberoi, and thank you very much, Karthik. It was a very, very nice presentation. It was very informative. Actually, I used to present on instability, starting actually from decision making, which I usually spend most of my presentation on decision making, because as Dr. Oberoi said, that's much more important even than the technical points. Which surgery for which patient exactly. And to be honest with you, in my practice, most of the failed instability surgery, I see it's just because of the wrong decision. Patient with bone loss more than 20–25%, and they insist to do arthroscopic Bankart repair for him. So my conclusion is that the decision making is very, very important in the instability surgery, and even in my opinion, it might be equal to the technical or even much more important than the technical point. So as we said, there is a lot of techniques for doing arthroscopic Bankart repair. There is a surgeon who's going beach chair, there is lateral decubitus, and there is a controversy about that. There is a lot of controversy about the anchors itself. Is it knotted, knotless, the combination? One portal, two portals, there is a lot of controversy. What I'm going to share with you exactly, it's the things which I'm doing in my practice, and it's working well, at least in my hands. So I'm a beach chair surgeon. I'm doing the Bankart repair and the rotator cuff on a beach chair position. That's my setup. I'm using arm articulating device. I'm using a Mayo stand on the opposite side. I just keep my shaver and arthrocare on the opposite side, and the rest in my hand this side. That's my setup. I'm usually turning the table 45 degrees to give myself and my assistant a space for that. I'm starting every single procedure in the shoulder with examination under anesthesia, which I highly recommend every single colleague from the young generation to keep this as a part of his practice. Do an examination under anesthesia before everything. That's usually the question to my fellows. What is the first step in shoulder arthroscopy? It should be examination under anesthesia. Since I'm a beach chair surgeon, I need to distract the glenohumeral joint as much as I can. That's why I'm using what we call it the axillary roll. It's a big roll of sterilized drape just underneath the axilla to distract the shoulder and open the glenohumeral joint. And you will appreciate the opening with these two videos. On the left side without this axillary roll, and with the right side when I use the axillary roll, how it opens the glenohumeral joint. That's why that's one of my tricks to the young surgeons. If you are a beach chair, if you are a lateral decubitus position, I think your life is much easier than this. Which portal I'm using? My posterior viewing portal. When I'm going for instability, I'm going 3 centimeters from the posterolateral border of the acromion medially and 3 centimeters down. That's my portal number A. But when I'm doing cuff or any subacromion procedure, I usually tend to go more up and more lateral for my viewing portal. Anteriorly, I'm using 2 portals. I'm using 2 cannulas through these 2 portals. The first portal, which is the mid-glenoid portal, just lateral to the acromion, just lateral to the coracoid. And the second portal, which is the anterosuperior lateral portal, and you can see it, how far should be both of them if you are using a cannula not to be overlapped. That's how they look from outside, and that's arthroscopic view, how they look from inside. The first portal is just above the upper border of subscapularis. That's a left shoulder viewing from posterior. And the other one is just behind. So I'm using size 7 cannula, going inside. Sometimes in a tiny shoulder, the superior portal, I tend to use the rubber cannula, the Passport from Arthrex, or even I'm not using a cannula in the in the superior portal, the anterosuperior portal. That's how they look from inside, the two cannulas in the rotator interval, one far down and the other one is just behind the superior, just behind the long head of biceps, and pushing the biceps up and down. You can move it up and down, superior and inferior to the long head of biceps. The first step in any, that's how they look from outside, mid-glenoid portal, and the other one in anterosuperior lateral portal. I start every single shoulder arthroscopy with a diagnostic arthroscopy. I do the 10 points diagnostic arthroscopy, starting with the superior labrum and biceps anchor. That's point 1 for me, viewing and probing. The second point is the glenoid cartilage, to see if there is any cartilage loss, if there is any degeneration. That's 2. Then I move the light source to the opposite side to see the humeral head articular cartilage. That's 3. Number 4 is the anterior and antero-inferior labrum. Again, viewing and probing. That's my routine in every single shoulder arthroscopy, whatever the pathology. I do the 10-point diagnostic arthroscopy. Then number 5 for me is the long head of biceps. Just grab it inside to see if there is any subluxation or there is any tendinitis. Number 6 is the subscapularis. So I just expose the subscapularis in this viewing and ask my assistant to do posterior lever push to expose it more. And sometimes if there is any downs, I do have the availability of 70-degree scope, sometimes using it. Then that's all done. So then structure number 7 for me is the supraspinatus and infraspinatus. Structure number 8 is the humeral head posteriorly to see the Hill-Sachs lesion, if there is any Hill-Sachs lesion, and to assess the size. Number 9 for me is the inferior gutter to look for any loose body or Hagel lesion. And finally, number 10 is the posterior labrum. And when I have any doubt, like in this patient, there is some fraying and there is suspicious of tear, I just switch my scope from anterior to see it like that. So that's the 10 points diagnostic arthroscopy I do for every single case, and I teach my fellows to do that. And then going to the labrum repair. So the first step in any labral repair after you establish your portals and everything is to preparation the bed of the labrum. I do use the tissue liberator, the rasp, the shaver. I use many instruments just to refresh the bed until I get a bleeding surface. I don't use the acrominizer. I feel it's very aggressive and it might increase my bone loss a bit, and there is no need for that. So motorized shaver, rasp, and liberator for me is more than enough. The second step, and the most important step for me, is the inferior anchor. For the inferior anchor, I tend to use the 5 o'clock portal, which is the percutaneous portal, to insert the far inferior anchor. And if you look, that's the mid-glenoid portal, that's the anterosuperior lateral portal, that's my 2 working portal. And here, number C, which is the 5 o'clock anchor, 5 o'clock portal. It's a percutaneous portal to insert the inferior anchor. You can appreciate that if you see the guide, this needle is coming from the 5 o'clock portal. You see how it is perpendicular to the glenoid, that's a left shoulder. And if you want to insert your anchor through the mid-glenoid portal, you can do that, but look at the obliquity of the direction, which might end up with a breakthrough the anterior rim of the glenoid. So it's percutaneous portal through the subscap. It's exactly like the one we sometimes used in the slab repair. That's how it looks, going through the substance of the subscapularis with a sharp tip and instrument over the guide. Then the guide is going there, and if you look at the guide, the direction is very fine, perpendicular to the glenoid. So it's a percutaneous small portal. I don't think it's very, I don't think it's not so traumatic to the subscapularis. And for me, that's the most important anchor. I have to spend a lot of time to make it perfect. You can go up, I usually go beyond 5:30 on the right shoulder. With this portal, you can reach up to 6 o'clock. Insert your anchor. I tend to do my inferior anchor, knotted anchor. And that's another very nice trick I encourage all the young surgeons to do it. Just always keep the labrum under tension by any like suture, or you can hold it with a grasper like that and ask your assistant to keep it elevated and up under tension. So you can do your puncture easily with a passing device, whatever you use. And the other point, look at the anchor level. Your puncture through the labrum should go below the level of the anchor itself. We tend to shift the labrum from down up. So your puncture should go below. When you tie your suture, keep the tension, and then you will shift this bite from down there up, and you will have a nice bumper and nice repair. That's what I'm doing. I'm checking the level. I'm going below the level. Keep the labrum always under tension. The secret of dissection is tension. I have 2 cannulas, so my life is easy. I can use the other one to grasp this passing wire, and always be careful for your knot. It should be on the other side of the articular cartilage. It shouldn't be here, it should be on this side. I think this is one of the basics. Just reminding you. Sliding knot, then I do 2 square knots, meaning that 4 half hitches. So I got a nice repair right now. I believe that it's back in place and it's under tension, and then that's fine. Going to the second anchor. The second anchor, it's very easy to do it from the mid-glenoid portal. You don't need to go through the subscap again. The obliquity is much less than if you go for the inferior anchor from the mid-glenoid portal. And here, that's the common question for the people, where exactly you go on the glenoid cartilage. I tend to go like 1 or 2 millimeters posterior. I'm not going at the edge here exactly, but I tend to go a bit on the articular surface, like 2 to 3 millimeters, to make the bumper on to shift the labrum to make it a tight repair. So drilling, anchor. I'm a fan of knotted anchor, especially the first two. It's the same step exactly and the same tracks. Always keep your labrum under tension. Like that, keep it under tension. When you tie your knot and when you do your piercing through the labrum itself to make your bite. So keep it, we need to shift the labrum from down up. So keep it under tension again. Tie your knot. Get a very nice Panelists and repair. Make it tight to looks like that. And then finally, the superior one, this is a kind of knotless anchor where you insert the anchor first. It's called the knotless suture tack. Again, take the bite. Here, the shifting from down to up is less important than the inferior two anchors. Passing and do your knotless repair. So I tend to use not less than 3 anchors. So every single repair, at least I do 3 anchors, if not 4. In this case particularly, I did 4 actually. There is 1 anchor up, I inserted it. So it's not in this video, but this is usually my routine. That's how exactly I do my Bankart repair, which I believe most of you have a different techniques, have a different tips and tricks, but I'm just showing with you what exactly I'm doing in my daily practice and working well with me. So my take-home message, the decision-making is very, very important. Most of the failure because of wrong decision. The setup and portal placement is very important. It might make your life easy and might make your life hard if your portals is not in the correct position. The auxiliary role for me is very good, especially for the beach chair surgeon. It's expanding and opening the glenohumeral joint for me. Labral bed preparation you have to spend. If you do like the Bankart repair in an hour, you should spend 40% of this time at least for preparation of the bed and preparation of the labrum, because this is very important. 5 o'clock portals, you can consider it if you are using a rigid anchors like I'm using. Shift from down up is very important, especially during passing the suture and also during tying the suture. And at least you should use 3 anchors or more, not less than 3 anchors. And this is an evidence-based medicine. It's not my personal opinion on that. Thank you very much.
Thank you, Dr. Usama. Indeed, a wonderful presentation, and your overview of exactly how you do step-by-step Bankart repair was quite impressive. Especially, I was quite impressed by the use of auxiliary towel, which you showed the sheet, and how it actually makes the space for your shoulder to arthroscopy surgeon to work. Your trans-subscap portal, the 5 o'clock portal, is very, very useful because it helps in putting your anchor in a much more easier manner and a much more anatomical manner, and then you can actually go more down, 536 as well. Quite impressive. And your statement that you spend a lot of time on preparing the glenoid bed is very, very important. I think the labrum has to unite with the bleeding bone, and excellent steps. Just one question before we can go in. Do you sometimes extend the labrum lesion from 6 o'clock to 6:30 also? There are some surgeons who extend the Bankart tier slightly more so that they are able to actually mobilize the capsulolabral complex more superiorly. So do you do that or you just don't do that?
No, I just don't do that actually. I stop where the labral tear is there. I might go like 1 or 2 millimeters just to be sure that this is a healthy labrum. but
Perfect.
I don't detach the healthy labrum just to shift it up down.
I think we'll have more questions coming up at the end of the discussion session. Overall, a wonderful presentation. Thank you very much for sharing your insights about arthroscopic Bankart repair. Let's go to our next presentation, Dr. Saeed Al Thani. He's going to talk about Remplissage, and I think, as I told you before as well, it's a procedure which is very, very useful, done usually in conjunction with Bankart repair, but often underutilized. Surgeons don't realize the importance of a Remplissage procedure, and they would rather not do it because they think it increases the complexity of the surgery. Our master like Dr. Thani might show us techniques where he will try to make it much more look simpler for even young arthroscopy surgeons to go ahead and do Remplissage whenever indicated in a case of a shoulder instability. So please share your screen, Dr. Thani, and we are eager to hear your presentation. And you can unmute yourself, sir.
Just 1 minute, I'm trying to get it up here.
It's clear now. You can share your screen, sir.
One second. One minute, please.
No worries.
No, it's not getting there.
No issues, no issues.
Till he's sharing the screen, Karthik, yeah, it is already screen. So we'll probably ask questions later.
So I was talking to Karthik and I said, Remplissage might be an interesting procedure which can be added to the armamentarium of what we use and how we manage. So when we talk about anterior stability, you know, most of it is, as we said here, it's mostly in young athletes, young guys, teenagers, most of them complicated by bone loss, and it can be up to 90% of the bone loss, whether at glenoid or in the Hill-Sachs. And the term Hill-Sachs was done and was used by Sachs and colleagues a long time ago. So we are not here to just go over it, but we have to remember the biomechanics and stability of the joint contribute by concavity and compression, and the bone structure plus the capsule and the muscle around it, which is the rotator cuff. So these are which maintain the stability of the shoulder. So if we have imbalance on these, then we can get instability. So when we assess, we need to look at these structures to see where the defect is. So if we want to assess the glenoid, we know that you can calculate it from the CT scan or arthroscopically, depends on how much loss on the bone, and that's important. When it comes to glenoid, we need to know, as Dr. Karthik mentioned, depends on the percentage, depends on the location, whether it is more down where it can engage or not. If you look here, you can see the glenoid is loss, and that's bring the articulating area from there to here. So it depends on the location of the of the lesion in the humeral head, where we can see whether it's engaging or not. So, as I said, this is the same, depends on the width of the glenoid as well. So a lot of way of assessing and measurement, but the most important things when you look at the defect itself, how big is it? You need to know, which Dr. Karthik was talking about, up to 17%, so consider small, or 17 to 25 consider big. For me, I made my judgment mainly intraoperatively. I examine the shoulder and I take it and I see if it's engaging intraoperatively, then it's engaging lesion. And then at this point, I'm already ready to do my Remplissage or Latarjet. And when I examine the patient with the bone loss, I'm always ready in the operating room to operate with a Latarjet or with Remplissage. Depends on the intraoperative final assessment. So when it comes to the, as you say, the track or track, you can see this is a tear, but it is not articulating. So the width of the glenoid can contain the defect without being engaging here, where if there's a bone loss, then even if the same lesion can be engaged and locked during the dislocation. And this is now it is totally different ball game, where we need to work on glenoid or on the humeral head or combined. So advantage, as we said, in the bone defect, simple bony Bankart can result in high recurrence rate. As the literature is up to 67%, and also recurrence rate of Bankart with Remplissage is comparable to arthroscopic Bankart in a patient with clinically insignificant Hill-Sachs lesion, which is around 10%. So when we combine the procedure, we bring down the recurrence rate to what normal Bankart can give. Also, its ability to make the Hill-Sachs sealed away and make it extra articularly and eliminate the engagement. But this procedure doesn't come without any pitfall. You need to know. Most of us look at the glenoid from, at the glenohumeral joint from the back. So if you don't have the proper scope, if you are not oriented, then you might not be able to see the Hill-Sachs properly. And also it's limited workplace posteriorly. Sometimes if you use a cannula, you might have a problem. I usually don't use any type of cannulas during my arthroscopy, not posteriorly or anteriorly. I just go free with so to allow me to manipulate around. Also, you have to improvise, and you have to know that I'm not going to use one portal to address the pathology. I might have to go back and forth when I address the procedure. You might need to go with the posterior lateral subacromial portal. You might need to go trans-cuff portal to visualize the repair. You might need to go to the anterior portal through the rotator interval to visualize. So you need to keep your switching stick ready for you to mobilize. It is easy for you to go around than your anchor and your instrument to move around, to give you better access, actually. I usually use this algorithm for what I do. If there is no bone loss or minimal bone loss, I would go with the arthroscopic Bankart. If there is a glenoid loss of less than 20 with Hill-Sachs less than 30, I usually have a good result with arthroscopic Bankart Repair and Remplissage. If it's more than that, then maybe bone grafting. The Hill-Sachs, especially if it's bigger Hill-Sachs lesion, and always think about Latarjet as a bale. I look at the humeral head as a golf ball, and the glenoid as the tee. And if you increase your, make your socket bigger, then the chance of dislocation is less. And arthroscopic repair was, as I say, part of the procedure. Dr. Usama talked nicely about it, about the steps and how to do it. So I'm not going to go there. I'm just going to go directly to how I do my Remplissage. So this is, you can see, this is anterior labrum is gone. This is the posterior Hill-Sachs lesion. It's posterior inferior here. You can see, and it will engage now. It's engaged there. So I go back and I look at it. I don't have a cannula so that I can see this socket properly. I go to the, I prepare. Since I want to do a Latarjet, Remplissage, what I will need. I need to tie the suture over the infraspinatus. So if I want to go and I put my anchors through the directly, what will happen when you will go to the subacromial space? What will happen is you will not be able to see your suture through the bursa. And then you might be able to shave your sutures. So I prepare the space first. I go first, I clean the subacromial space completely. I know when I will come next, maybe they will see some clot, but there is no bursa, so I can visualize my suture easily after I insert my anchors. And this is what I'm doing here. So I go out, I open posterior lateral portal, I go directly and I shave using posterior portal to the subacromial space. Then I go to inside again and I prepare the bed. I identify where I will be opening my, I will inserting my anchor through a separate portal. I put my shaver, I shave the bone to increase the healing of the cuff to the humerus. Then I insert my anchor. I usually use PEEK material. This is, I usually put 2 to allow it. Once we pass it there, then this is another, I couldn't get that video properly, so I have this combination between 2 videos from different procedure. So this is here was a small glenoid, so I couldn't put 2, smaller humerus, so I couldn't put 2, so I put 1 double loaded anchor. And I use my per PEEK to pass the suture through. Then I came to the subacromial space. You see, I cleaned it already before, so now I don't have a problem. I can see my suture, and then it will be just a suture management tying over the infraspinatus, and you just cut your anchors at the end, like what we do usually with these things. You can see I tie the first the white and now the blue. This is the same concept. You can use what do you call it? You can use a continuous sutures if you tie them together, but I like to prepare each one separately. And so that's simply how you avoid having a problem with the Remplissage. You have to be take-home messages. You have to have a preoperative assessment, which is crucial, and you have to be ready in the operating room to address what you need to address. I'm lucky that I have my own stock of instrument, so because of the volume I do, so I can switch management immediately. But if you don't have this, you have to be prepared to deal with it. The more investigation you do preoperatively, like a CT scan, to assess the size of the defect, is important. It's indicated for off-track bipolar pathology. Visualization, as I said, is an issue. You might need to change portal during the procedure to be able to see how it's closing the gap. And it's all about suture management. Thank you.
Thank you very much, Dr. Thani. I think wonderful presentation, especially the way you showed that you have to clear the subacromial space before to actually see the sutures and then tie them under vision is much important. Most of the surgeons I understand would actually not go into subacromial space, but would just tie the sutures, and that probably also there's a question of knot security and loop security there, and you're never sure that your intraspinatus is sitting very well. I think
the problem with that, they will suture over deltoid fibers,
absolutely,
and that will cause tremendous pain and stiffness to the patient
yes,
beyond what you are going there for. So it's better to clear before you insert the anchors, because if you insert the anchors, the shaver might take your suture out, cut it for you. So it's better to clean before you insert.
So do you use sometimes more than one anchor as well if the Hill-Sachs
Yes.
is large? Okay.
Depends on how big it is. Uh, I have one guy was a huge tear. At the same time, uh, he had subtotal infraspinatus tear. So I repaired the infraspinatus to the defect, and it was huge that I need to put 3 medial row and 3 lateral row anchors, so 6 anchors just to fill the defect.
Yeah.
But it was this is now 8 years. I'm still doing well.
Wonderful. That's a different injury actually pattern, because then you have an infraspinatus which is also torn, and you took the advantage of infraspinatus actually putting it onto the Hill-Sachs lesion. So
it's a different pathology. Yes, I agree with you.
So Dr. Oberoi,
we'll just keep the questions at the end of the session. Yeah, Dr. Usama.
Yeah, I just want to add one small comment about looking for the suture after applying the anchors. I know it's difficult and you might code the suture by the shaver. There is a small trick which I used to do to protect my suture, that I slide the knot pusher over the suture itself. And when I'm hitting in the undersurface, I mean the subacromial space, I'm just be careful with my knot pusher rather than be careful with my suture itself. So that's a kind of protection of the suture, because I insert the anchors first. Like I think that's like everybody is doing. I insert the 2 anchors in the Remplissage. I use only 2 anchors. Then I finish my Bankart repair. Then I go back to tie the suture in the subacromial space.
Yes.
You try it, Osama. Just do the cleaning first. It will be wonderful. You can see them very well. And if you know that you're going to do a Remplissage from the before, just do it before you go to the glenohumeral joint even.
Yeah. Once you have clinically decided pre-operatively that you would do a Remplissage in such cases, always a good idea to actually do a subacromial cleaning and then do your routine Bankart followed by a Remplissage knot tying. We have the last presentation, Dr. Senthil. Dr. Senthil is from MIAT in Chennai. He's going to talk about mini open Latarjet. So Senthil, if you can share your screen, and then we can have your presentation followed by some questions to entire faculty and panelists, so that we can have fruitful discussions at the end of the session.
Okay.
Yeah.
So first of all, thank you for the opportunity, Dr. Karthik, and thank you, Dr. Oberoi. So it's actually not mini open Latarjet. I use the normal incision for the Latarjet. So because incision actually should not matter because it heals from side to side. So these are my disclosures, and as we already talked about a lot on decision making. Karthik gave a wonderful talk on the osseous deficiencies in the glenoid and also the Hill-Sachs lesion. We need to understand that this is actually a time tested procedure, the Latarjet. So we'll just go through where it is actually indicated, and then move on to some technical tips and how we can actually avoid complications with that of the Latarjet procedure. We know that if there is significant bone loss, the soft tissue procedures don't work, because whenever there is bone loss up to 25% or more than 25%, there is significant compromise with the soft tissue repair alone, and this has been already shown in a number of studies. And now, as glenoid track has been coming into vogue, and it has been shown again and again that the Hill-Sachs lesion combined with that of an osseous lesion, it can affect the glenohumeral joint stability. And so the Latarjet is the procedure that will actually address this when you have 25% of glenoid surface area, osseous lesion. So for that, you need make sure that you get adequate preoperative planning, and then decide on, whether you're going to do a soft tissue or a Latarjet, bony procedure. So Bankart et al. Have shown that with soft tissue procedure, when there is no bone loss, the recurrence rates are lower. But when you have in their description an inverted peer appearance, where this describes that there is significant bone loss, there is more than 60% recurrence, and this is because you're attaching the soft tissues back onto a deficient glenoid, and so this can lead to significant failures. And again, Pascal, in his ICIS score, it is again, shown that, the ICIS score also depends upon the factors of glenoid bone loss, as well as the Hill-Sachs lesion and associated hyperlaxity. But this, they are based upon their external rotation radiographs and the loss of the bone contour in the glenoid. So again, the bone loss scenario is very important here, where when the score is more than 7, then we tend to actually move towards a bony procedure. So bone loss scenarios again are often underappreciated. We know the study from Sugaya that the amount of osseous deficiencies actually is always underappreciated, and if you actually adequately screen them, a lot of them are actually attritional bone loss, which can actually happen over a period of time. And also the number of times you actually find that the incidence of these bone loss scenarios is quite high, than actually we assume that they may not be. So this concept of subcritical bone loss, again, it was covered by my previous speaker. What happens when you actually have a less than 25% bone loss scenarios in high demand patients, in the overhead athletes, in the military subgroup, those kind of patients who have significant overhead activities, less than 25, 17 to 25% of glenoid bone loss. Again, this again may need a bony augmentation rather than actually a soft tissue procedure. So this is again been shown by studies that the Latarjet procedure carries a significantly lower risk of dislocation in these overhead athlete population group. And in fact, regardless of the clinical scores and the rate of return sports obviously were better in these competitive athlete group.
I think some problem with the internet of Senthil or what? Hello.
Dr. Senthil, can you hear us?
So I think there's some connectivity issue. I'll call him.
Yeah, please do call.
Probably some internet issues.
I think he is having across some internet issues.
Yeah.
He's back, I guess. He's back.
Sorry, I just got disconnected because the current went off and my router just went off. Are you able to hear me back?
You're perfect.
Yes, until we can hear you. You can share your screen.
Yeah, sure. Yes. So did I disconnect on this slide? Is that correct? Karthik?
Yeah, I think you were just before this slide, one slide before.
Just before this slide, yeah.
Yes, exactly on this.
So yeah, it is a time-tested procedure, and we know that there is a difference between the Bristow and the Latarjet procedure, and also the Latarjet procedure confers more superior stabilization in terms of the in vitro biomechanical studies. So why Latarjet, is that, compared to that of, any other bone graft procedure like a Eden hibernate, primarily is that it is a single incision, less donor site morbidity, and it has a triple blocking effect, right from actually having the sling action of the subscapularis, preventing the shoulder dislocation in abduction, external rotation position, and also giving the extra amount of augmentation through the bone block of the coracoid. And more often it addresses the humeral defect as well, indirectly, because it increases the arc. More often, even when there is a humeral defect, if there is a significant osseous defect, only the Latarjet procedure, is sufficient. So the bipolar bone loss on the glenoid track has been extensively, covered. So I will actually, skip through these slides, but we need to know the concept of the on-track and the off-track lesion, because the glenoid osseous deficiency plays a significant part, in which to decide whether it is an on-track or an off-track lesion. So with the CT scan and the tracking CT, now we are able to make a decision on preoperatively whether you'll be doing a procedure which is only a soft tissue procedure or a bony procedure. So these groups where there is a significant glenoid defect of more than 25% plus an on-track lesion, we do a Latarjet. And then, even if there is a off-track lesion, still, practical purposes, we do a Latarjet, and very rarely, only if there is a significant, Hill-Sachs deep defect, where it is cannot be, addressed, do we actually, go in for a bone graft or an additional remplissage. More often, from a practical standpoint of view, more than 25% bone loss, whether it is an on or an off-track, more often, the Latarjet will be adequate. So this is a standard Latarjet procedure. We will go through the video of it. And also there is a congruent arc modification, which was actually De Beer, who actually took the coracoid and actually rotated it in such a way about its long axis. So that actually increased the joint surface. But indirectly what happened was that we often find that when you actually do a congruent arc Latarjet, you won't be able to actually approximate the capsule to it. That is one of the, practical difficulty we find. And also in vitro study shows that the glenohumeral joint loading mechanics actually is restored to more or less intact condition. But the studies have actually shown that the results of a congruent arc Latarjet to that of a normal Latarjet, the results are the same. And there is no difference in the clinical outcome between whether you do a standard Latarjet or a congruent Latarjet. The only in vitro biomechanical studies have shown that the magnitude of anterior humeral translation is actually reduced when you're actually doing a congruent Latarjet, but it doesn't translate to a clinical, superiority. So let's go through quickly with that of the step Latarjet procedure. Usually the incision is, once you decide on the Latarjet procedure, the incision is actually quite medial compared to that of a standard deltopectoral approach. With this approach, it is, the superficial fascia is actually dissected out, and you can palpate the coracoid, and then you go in and then dissect out. You find out the conjoint tendon, and then feel for the coracoid directly, and you can see that you're approaching the conjoint tendon there. And then the important feature is that you try and actually make sure that you get a retractor just above that of the coracoid, and make sure that you actually can release the both medially and laterally, by making sure that you don't go 2.5 centimeters below the coracoid, because you can inadvertently damage musculoskeletal. Adequate release of the conjoint tendon is done, and then you actually also release the coracoacromial ligament, and you actually leave a bit of stump on it, so that you can be repaired back to that of the capsule. And then now you can actually go medial to it and then release the pectoralis minor, and then that will actually almost skeletonize the coracoid, and then you can actually adequately release the undersurface of the coracoid as well, and you can see them clearly. So once you do that, ideally, if you can actually use a 90-degree saw blade, it is very useful. But otherwise, also you can, to avoid any fracture of the coracoid, the tip is to actually make multiple drill holes using marking with a cautery. And then you actually, weaken the coracoid and then do an osteotomy. Then that would be actually quite useful. And then also make sure that your angulation is not significant enough to actually go into that of the glenoid. So that is another important step. Sometimes if you actually use excessive force, you can actually, even fracture the glenoid if the angulation is blind. So you make sure that you can actually see the where your osteotomy is being made, throughout. And then subsequently, you can free up the coracoid. Always you will see that there is a bony spike that is actually along with that other coracoid. So you make sure that you can that the coracoid itself, the part which is actually going to be opposed is actually clearly decorticated, so that you can actually get a good opposing surface, or that is actually applied onto that of the glenoid. So that once it is decorticated, you can actually measure your cortical size, the coracoid size, and usually it should be, more than, so that it is adequate to actually have at least 2 screws. Because biomechanically, again, using 1 screw, you will not get that adequate amount of rotational stability. There are different ways of actually doing this. One way is actually, easier way is to actually do the drill holes, outside, because then you would have a better control of the coracoid when you're actually applying it. So you can actually, space them apart as well, so that you can actually, have difficulty when you're actually drilling it. So once you do that, then to the subscapularis, the next layer, and then lower two-third junction, you make horizontal split. And again, there are different ways of approaching this, but this is the most commoner and safe way. And you should also make sure that you don't go too blindly medially, because you have all the important, vascular.
I think we lost Dr. Senthil again because of some technical
Yeah, I
issue.
think.
Yeah.
We'll try to reconnect again, I think.
Yeah, in a minute. Pinky, are you trying to contact him?
Yes, I'm trying to call him.
He's back.
Sorry, I think I was just on the video.
No.
Yes. So once we actually get onto the capsule, we make again a vertical split. So this is to make sure that you can actually repair some amount of capsular, so that and keep the graft extracapsular. So that is another, and then you can get your Fukuda retractor inside the head and make sure you have adequate exposure of the glenoid itself. And there are a few tips, like you can actually, make sure you can get a retractor by actually putting a pin on the top of the glenoid. Then you get a very good exposure, and also the glenoid retractor, which is actually put on the scapular neck, and you get a beautiful exposure of the part of the glenoid, end face view of the glenoid, so you can actually see the edge of the glenoid very clearly, and then you would be able to approach with the graft. Most often, the improper positioning of the graft is because you don't get enough vision, adequate visualization. So you must invest in good shoulder instrumentation so that you get the proper glenoid retractors, proper Fukuda retractors, so that you can actually get proper visualization. So once that is done, then you actually decorticate the edge of the glenoid and make sure, again, you can use the cannulated screw as well, but more often if there is adequate vision, you can do it under vision and make sure you get good, you go parallel, to that of the glenoid, and make sure that you're not veering away more than 10 degrees. And that would actually give you, make sure that you don't hit the suprascapular nerve if you stay within 10 degrees of the end face view of the glenoid. And once that is done, then you can actually put the measure, and then once the measuring is done, then you can actually get the screw. Usually we can use usually used as a partially threaded screw, so that you can get adequate compression, and 2 screws are usually used, and you also must make sure that it is not over tightened. If you over tighten, there is a risk of coracoid fracture. So that's one of them. And then the other screw is actually applied on top of it, and the rest of the coracoacromial ligament is actually sutured back onto that of the rest of the remaining capsule, so that you get adequate amount of coverage anteriorly as well. So that, in essence, make sure, that that's a technique of the Latarjet procedure. But in a few pointers is that the graft should be actually placed below the equator, because if you place the graft too superior, then there is a risk of injury to the suprascapular nerve. And especially the cadaveric studies have shown that the placement of the screw should be within that 10 degree of phase of the glenoid, so that is a safe arc, so to prevent any suprascapular nerve injury. And also, when you're doing the coracoid osteotomy, you should not veer away medially. So you have to make sure you have an elevator beneath the coracoid, and also to preserve the blood supply of the coracoid, because the blood supply runs along the more medial aspect of the conjoint tendon. So you have to make sure that you don't actually, strip off all the soft tissue of the conjoint tendon as well. And the position of the screws, it should not be too inferior, because if it is too inferior, you will not have insufficient purchase. And also intraoperative fractures can be avoided if you can actually add a washer to your screws. What to fix the screw with nowadays, there are more methods, like, apart from the cannulated screws, people have started using endo buttons as well. Using even 2 cortical screws, 2 cannulated screws, or endo button, all of them have equal biomechanical strength. But a single screw is usually insufficient, and because it does not confer the rotational stability. Whether you use a cannulated screw or a non-cannulated screw, the energy to failure is the same. So there's no statistical difference. You can use as long as they have good stability. Using a lag principle, if you can actually get a good compression, 3.5 or a 4 mm screw, but important is to actually stay perpendicular to the coracoid, so that you don't actually, veer away in an angle. And as I said, it should be within 10 degrees, 10% of the face of the glenoid, so that you don't actually, disturb the suprascapular nerve if you go very medially. When you're using instrumentation, you have to be careful, because the musculocutaneous nerve, it actually runs about 4 centimeters approximately below the tip of the coracoid. So you should be careful that you actually do digital palpation, and also instrument should not be actually put in blindly. And if you have a 90-degree oscillating saw, it is actually very good. But if you do not, you should actually make sure that you can, without using the osteotome directly, if you can actually weaken the coracoid by either using a burr or by actually using multiple drill holes, after marking it using diathermy, then it will be actually preventing any coracoid inadvertent fractures. So this was the musculocutaneous nerve I was talking about. So you have to make sure that you actually don't blindly dissect out the whole conjoint tendon or put blind instruments after you've actually, stripped away the coracoid along with the conjoint tendon, to make sure that you don't damage the musculocutaneous nerve. So we know that excessive medialization fails to improve the glenohumeral stability. That's very important. So you have to stay, end phase to that of the glenoid. And excessive lateralization, it has been shown that it causes degenerative arthropathy. And the capsular repair, when you're doing it, it has to be made sure that you don't actually, it has to be, arm should be positioned in internal rotation or in neutral rotation rather than actually, if you actually put it in too much amount of rotation, then you can actually have loss of external rotation. So that is, you have to, suture them in neutral rotation rather than actually internal rotation. So osteolysis, this is another hot topic. After, in the recent past, we have found that, if you follow up these Latarjet procedures, there is a significant amount of osteolysis in these graphs, but the clinical significance is not completely understood because not all of them actually go on to failure. So it begins now it begins us to, asks us the question whether actually it is a graft which is actually causing the stability, or is it just even if you actually put in a stump which will actually give us a proper stability. So there are some studies which actually shows that some cadaveric studies which show that even without the graft, just putting a conjoint tendon anteriorly will actually provide some amount of stability. So it now questions us whether it is actually the osseous effect that is actually producing the stability. But some cadaveric studies have shown that you actually have to put in the coracoid to actually get amount of arc. So for all practical purposes, we have to look out for osteolysis. The osteolysis is actually being observed more and more now that we are having access to CT scans post-operatively, but not all of them lead to clinical failures. So we'll have to wait and watch on this. So some patients, about 4% of the patients have been shown to go into pseudoarthrosis, but if you have good compression, then you can achieve good amount of graft union. And as I said about osteolysis, you'll have to watch out for. So post Latarjet arthropathy, it happens in the long-term studies by Hovelius. In 10 years follow-up, 20% had arthritis, and also at a 25 years follow-up, almost 50% had arthritis. So, but all of them did not manifest clinically. So it essentially means that it may not be that the graft itself is causing the arthritis. It may be that they are already having the injury primarily after these dislocations, and this can cause chondral injuries, and these progress to actually arthropathies rather than actually secondary to the graft itself. So this also has to be kept in mind. So newer methodologies like arthroscopic Latarjet procedures have come to the foray, and it has got a significant steep learning curve. It offers better visualization, but again, results have shown that open versus arthroscopic Latarjet procedures, clinically the results are the same in the long term, although the pain scores are better in the early postoperative period. So take-home points is that 25% bone loss glenoid, Latarjet procedure, subcritical bone loss in overhead athletes, again, Latarjet, make sure you don't medialize or laterally overhang the graft, and adequately follow them up so that there is no osteolysis of the graft. And radiological arthritis does happen in spite of whatever fixation you do, but whether they clinically manifest or not is a big question. Thank you.
Thank you, Senthil. I think with your presentation, we end all the 4 presentations. Thank you for a wonderful discussions which are going to happen now. I think, Karthik, how do we want, can we have some questions on the chat box? If you can put it, could I just maybe start some questions from each of the presenters?
Yes, you can start with the question. You want me to proceed, or you can proceed with the questions?
So I can maybe just ask maybe Senthil, because he is the last presenter, and then we can have some questions to Dr. Usama and Dr. Saeed and yourself as well. Senthil, when is your indication when you start using an iliac crest graft? Is it always that in a bone loss you do a Latarjet, or sometimes you would go in for an iliac crest, free iliac crest graft as well?
Yeah. I think my preference of doing the Eden Hibernate is usually for a failure of Latarjet procedure, because that's almost like the end point. So my indication primarily for a bone loss situation in a 25% or more bone loss would be a coracoid, a Latarjet procedure. So Eden Hibernate iliac crest bone graft only for failed Latarjet and not as a primary procedure.
Dr. Usama, Dr. Saeed, other than failure of a Latarjet, would you primarily do an iliac crest graft in a bone loss situation in some cases?
For me personally, I do completely agree with the Senthil. That's the only indication for me is failed Latarjet. I just keep it as a salvage procedure at the end of failure of Latarjet, but I don't do it primarily.
Dr. Saeed?
I agree also with this, though if it's failed, I will think about distal tibia as an allograft as a bony support for the glenoid. Iliac crest, I consider it's very painful procedure. So, and if the patient can afford having an allograft from a distal tibia, which can be contoured nicely with the glenoid, that will be my next choice. If he cannot afford it, then iliac crest is a reasonable choice as well.
I think with the coracoid graft, I think your addition of a sling effect is also one thing which has got an additional advantage to these free grafts. And probably that's the reason for all of the panelists here and speakers to use do Latarjet rather than a free iliac crest graft as a primary scenario for bone loss situation. In new plates which are commercial available, these are mini small Latarjet plates.
Yeah.
When you compared about the cannulated screw, you also talked about endo button. But why these companies are coming up with these plates? Do they have some biomechanical advantages over single two screws?
Actually, I had that slide, but there was too many slides, so I didn't actually include them. The mini 8 plates, they have been in the market for a while now, and they do provide some amount of advantage to the surgeon that you actually feel that you're compressing the graft and you're actually getting uniform compression. But the in vitro studies actually do not show that actually using these 8 plates are providing more uniform compression than actually using 2 cannulated screws. So yes, you will feel better when we actually use. But I think one advantage is that you don't have to use a washer with these mini plates, and also the prevention of coracoid fracture that can be prevented. Just for providing more compression, no. But to prevent coracoid fracture, yes, it will be useful.
I think Arthrex has these plates. Dr. Saeed, you are an Arthrex user. Do you use these plates or you don't use these plates?
Well, I use it,
Okay.
but sometimes, during the Corona period, sometimes we get a short of supply. So I usually use regular screws, compression screws like cannulated screws, which can work nicely with the washer, especially if it's a big size. I can go with 4.5. If it's the patient is a small in size, I can go with the regular 3.5, not even cannulated one, just a simple one. I put a K-wire on the line, I drill over it, and then I keep one K-wire on the second hole just to maintain the position. Then I switch between them with the screws.
So, Senthil, in any of the case, do you change the level in which you are going to do a subscap? Is your level of subscap slit always decided every time it is same, or in a multi-directional you would probably change the way you place where you're going to do a subscap slit? And then
usually, my subscapular split usually stays the same, Dr. I.P.S. Because I understand why you are asking this, because whether you want to do more amount of capsular tightening to prevent more amount of laxity. No, I think in such a situation where there is laxity associated with that of a bone loss scenario, still I think just by tightening the subscapularis, I don't think we would be achieving more amount of stability. So the osseous stability would be actually provided irrespective of where the subscapular split would be.
Dr. Usama, Dr. Thani, Dr. Karthik agreed with this, or you also have a standard place where you're going to do a subscap split, or you would actually change it in a case in a hyperlax individual?
No, I think what I do is I use the same. I split it in the middle, and I usually take the CA ligament where I can suture it to the capsule, as well as I try to peel the capsule, the labrum nicely, and I try to repair some of that labrum back to the tendon itself, just to give it another advantage by tightening the capsule as well.
So which means you make the bone graft extra articular.
Yeah, no. What I do, I peel the labrum of the glenoid, so it is redundancy now. So I put the bone and then I put a suture through the labrum and I pull it all the way around the bony fragment itself.
And you put an anchor there to fix it. How do you do that?
No, just a suture. I tie a suture.
Okay, perfect. Karthik, you had something to speak.
Yeah, that's what I so there was a small question from my side to Dr. Senthil and the panel. There's a subset of surgeons across the globe who still talk on repairing back the labrum after a Latarjet, as you had pointed out, with anchors with multiple portion. What's the panel's take on that? They claim it to be more proprioceptive.
Yeah. Actually,
so okay, Senthil, go ahead. It's your subject.
No, it's just my talk.
Then I'll follow you.
Yeah, ideally description is the triple effect of, the Bankart repair, open Bankart repair, plus sling, plus the bony, extension of the glenoid. But in practicality, what we actually see, is that, once you actually give an osseous, extension to the glenoid and the capsular repair, I usually don't repair that's my personal preference. I don't usually repair the Bankart onto it. Actually, once you are, there is an argument about the proprioception, but once you actually put in the graft, maybe that amount of Bankart repair is going to be almost redundant because, you are actually providing another significant extension to it. That's my take on it, because practically I don't find it as useful as it should be.
Senthil, you in your presentation told that you put a fiber wire suture in the wire of the screw. So where do you use that fiber? To stitch the capsule back, isn't it?
Yes, stitch the capsule back, because most often you find that when you actually split it, you don't actually, if you don't have it already, the coracoacromial ligament, sometimes the stump is too small and you won't be able to repair the capsule back. So that will actually act as, one more spot where you can actually repair the capsule back.
I think Dr. Usama has a point to add on.
No, I'm just commenting on that. For me, I'm splitting the subscap every time is the same, upper 2/3, 1/3. It's not 50-50 for me. Whatever the situation, that's how I do my Latarjet. I get a stamp of the CA ligament and suture it to the capsule, but my Latarjet is always intracapsule. It's not extracapsule. I don't repair the labrum. I don't find any reason, to be honest, to repair the labrum. And if you guys are aware of the recent study from Rush University comparing the Latarjet versus the distal tibial allograft, they do always exactly the same. Meaning that we have to rethink about the sling effect, and it's the most important effect. Actually, with this study, the conclusion that increasing the glenoid arc is the paramount, is the most important factor to get as a conclusion of that, because the distal tibial allograft, it's increased the glenoid arc, but it's not, there is no sling effect, and they do work very well, exactly the same like the Latarjet.
In fact, to add, Dr. Usama, the distal clavicular, autographs, again has been shown to have equally good results,
exactly.
because it's locally available, no coracoid, revisions are easier. but again, you know, time has to tell, because Latarjet has got a record of more than 40 years, 50 years now. So that's,
I think the shape of coracoid sits so beautifully that it is presumed that coracoid has been made.
Yeah, especially in the congruent arc fashion. Yes.
Absolutely, absolutely. Dr. Thani,
So
just
I'll ask you guys, any one of you is doing the congruent arc? Any one of you is doing the same like Steve Bankart is doing, and suture the capsule back, making the bone block as an extra capsule? And how is your results?
Very rare instance, especially for tennis players. I had a case recently, because I do not have long-term follow-up to substantiate, but I feel especially in tennis, proprioception is involved. And as you told, I keep 3 anchors, sutured inferior inferior 1/3, middle and superior, different positions of shoulder, which mimic the native anatomy. Now it's been around 1 year follow-up, and he's a junior level national player tennis. He does good, but I do not have lot of patients in mind to comment on comparison stuff.
Dr. Oberoi?
no, I don't make it extra articular. So.
And you do the classic Latarjet, not the congruent arc. Okay.
The classic one, not the common. So, Dr. Thani, we had a question. I mean, for Remplissage, you were using a bio anchor.
No, I use beak.
Oh, it's a peak anchor. So that's okay. So that answers our question, because yeah.
One question to Dr. Senthil and also to the panel regarding the suturing back of capsule to the CA stump, which was, all of us know, like Gilswatch has propagated it. There is always a take on loss of external rotation that you were talking about. Especially, do we need to curtail this step in a subset of patients or athletes who tend to have, rely on their external rotation, like your tennis players or your bowlers, especially on the cricket side, Indian part of it, especially in the bowlers? Do you think that we need to take a mind on that?
I mean, all the steps, as theoretically there is a possibility that you could limit the rotation, but actually the capsule stretches out, how much ever you, and also the amount of tightness that you can actually get with that coracoacromial stump and the capsule. More often you'll be able to get only the inferior part, and then you'll say, okay, I'll accept it. More often you will not be able to get all of the capsule repaired. So actually, the answer from my point of view, for all, even the contact athletes that I do the Latarjet, I do exactly the same, and I don't see any significant loss of rotation because of the Latarjet. In fact, with the Latarjet, they are more stabler, or you feel that the patients feel that they are more stabler very earlier on, and you start range of movement earlier on compared to that of the Bankarts. So the protocols are slightly different for the athletes anyway. So I don't see any loss of rotation. So far I haven't seen with them.
One more question to the panel as curiosity. Has anyone in the panel added a Remplissage to a Latarjet? I haven't got till now.
I had no experience with that. Never did it.
Oberoi, sir?
No.
Just out of curiosity.
Dr. Usama, do you in your Bankart Repair use these new all suture anchors?
Yeah, I start using it, and I'm so happy with that. To be honest, I was hesitant long time to use it because of the bone quality, especially in our Middle Eastern patient here. But slowly, I start using it, and guess what? I start using it even in the rotator cuff repair, where the bone is more softer than the glenoid part, and it did work well with me. I start using it more and more actually in the Bankart Repair. The idea that you can do multiple anchors without losing any bone, because the drill bit is much smaller than, and the good point as well With this all suture anchor or the soft anchors, there is a curved guide where you can use the mid-glenoid portal to reach deep down up to 6 o'clock without the need for my 5 o'clock portals.
But don't you have realized that now you have started using probably more than 3 anchors once you have started using these soft anchors?
Yes,
maybe you are putting 4 and sometimes 5 as well, isn't it?
It is, yes.
Yeah.
You're completely
Always
right.
like that, because you preserve so much of bone that you feel like putting one more because you have space, and then you try to maybe make your repair much more stronger with that.
Yeah, I do agree with you.
Absolutely. Do you sometimes do posterior capsular plication as well, Dr. Usama? There is, with recurrent instability with the Bankart tear, there is often an overstretch and plastic deformation of the posterior inferior capsule. So do you address that deformation also by doing some kind of capsular plication in a lax, multiply dislocated patient without bone loss?
I know theoretically, yes. I know there is few people is doing that, but I don't do that.
I have a question for the.
I don't do that.
Dr. Saeed, do you in your Bankart repair do sometimes some kind of surgical procedure to the posterior inferior capsule as well?
Well, this is one of the things. I looked at the stability and how bad is the injury. If I find that this patient have kind of the capsule is soft and it is worn off, I sometimes I go cross over to the other side. I use posterior inferior portal to the sulcus, where I can pass my suture lasso with the suture on the inferior sulcus, as if I'm doing application and tightening the inferior sulcus, but I cross to the other side. If it is a right shoulder, I will go to the 7 o'clock, sometime 8 o'clock, and I will visualize my fixation from the front and tighten it from the back. Just to complete from 2 o'clock all the way to about 7 or 8 o'clock.
Like restoring the hammock back onto the place. Perfect. Perfect.
May I add to your comment, Dr. Oberoi, that maybe I'm not doing this too much because I'm a big fan of the Remplissage, and I added it a lot to my Bankart repair. So in the Remplissage, you know that you tighten the posterior capsule by the tenodesis of the posterior capsule with the infraspinatus.
Yes.
Just one more question to the panel.
Yes.
Do you use Remplissage even when there is no significant tracking abnormality? Now that it's been shown that Remplissage is not significantly affecting external rotation anyway. So why not add Remplissage to all the procedures? So it's like belt and braces.
For me, I think Senthil, if the capsule quality is not great in the front, I'm doing a Bankart, there is hardly any bone loss. It's a plain anterior inferior labrum tear, but the capsule is not great. I would rather add a Remplissage because it just gives an additional security to me. So I think Dr. Thani and Dr. Usama and Karthik can add something.
It's in my practice, I don't do it in every single patient, but I do it in more than 50% of my Bankart repair. I have to get a significant Hill-Sachs lesion to add the Remplissage. Otherwise, I just keep the normal anatomy. If I have a patient with one dislocation, first time dislocation, and he is willing to go for the surgery, especially if he is younger than 25 years old, I do only for him Bankart repair without Remplissage. But if you ask me about the percentage, the Remplissage is about 60 to 70% of my Bankart repair.
Yeah, but for sure it is increasing now, because I think a couple of years back we were hardly doing a Remplissage, and now it is increasing in our practice. Dr. Saeed, when there is a Hill-Sachs which is a bit more medialized Hill-Sachs, is there some modification on a Remplissage? Don't you feel if you're going to do a Remplissage in a slightly more medialized Hill-Sachs will cause some restriction in the rotations?
Well, You know that these patients are, I believe that people who get dislocation, they are prone for having dislocation. There is something to do with their soft tissue. So these guys, they restore their range of motion very soon, even if we tighten them. So I'm not worried about it at all.
Perfect.
By 6 months, they go as if they have full range of motion, in my experience.
Perfect.
What's the panel's take on knotless anchors? I mean, I know they have come in and it's been significantly used more in the UK.
I think
and
Dr.
in
Usama
US.
showed, I think, how wonderfully knotless anchors have a role in Bankart repair. Dr. Usama, do you now, you showed that at around 5:30, you use a knotted and then a knotless above. But now you have shifted entirely to a knotless from down to above, or is it still a combination of knotted and a knotless?
In my hand, it's still a combination. I feel more secured when I do a knotted anchor inferiorly, and the superior anchor, I don't mind to use it knotless anchor. I use more knotless anchor in the posterior Bankart lesion, where tying a knot and all of that, it's not an easy job. But in anterior Bankart, I tend to use knotted anchor inferiorly. The first one down or the two down, and then after that I do knotless anchors. I know evidence-based medicine, there is no significant difference between both of them, and there is a controversy till now, but that's what I do in my hand.
And contrary, on the last 10 years, I never put any knotted anchor in any Bankart or slab.
Knotless.
All knotless since 2010.
Practice, and I think people have realized that knotless anchors do have an excellent outcome. So we initially started knotless with slab tears because we never wanted knots onto the superior labrum area, but subsequently we shifted to posterior instability. We started using knotless, and the confidence level has made us now to do for anterior instability and also for global plications as well. So I think we do have knotless anchors which are in armamentarium. There are surgeons who are still confident about the knot security. They feel the tissue.
I'm one of them.
So Dr.
The
Osama
field,
is still younger, but he's school thought.
Well, you see the problem. You worried about your knotless when it comes to a soft bone, and luckily that these young patients with dislocation, the glenoid is the strongest bone they have. So I'm not worried about my knotless anchor in these cases. And actually, I usually pass my suture through the labrum and I pull it up inferior superior shift and I see where I will take it. Then I will drill that point. So I'm not sticking to this 5 o'clock, 3 o'clock, or 6 o'clock. I just take this tissue where I want and I drill my anchor where I need.
Absolutely.
So
it's a tissue first and then anchor later. So
yes,
you can actually play with the place where you want, where you get the best mobilization of the capsular neural.
And I keep the arm. You see, with Osama, he put the table, the mice stand on the opposite side. I usually put. I don't use Tremano or traction. I let the arm hang by gravity. If the repair is not strong enough to hold the gravity weight of the arm, it's not good enough. So when it comes to doing my Bankart, I put the arm on the Mayo stand. I put some tissue to protect it from the edges, and I put the arm in 30 degrees of external rotation, just to maintain that I not tighten the arm more than what it should be. Yes, to pass the tissue, I put the arm in internal rotation to pass my anchor through the labrum. But at the tightening point, I put them in 30 degrees of external rotation, then I tighten. And I'm happy with that. This is the tricks I learned from the days when we used to do open repair for Bankart. We always keep them in 30-degree of external rotation, and I continue to do that with my Bankart arthroscopically.
I think in a B-chair position, the gravity has an important role. And I think Tremano also you use basically just to hold the arm rather than to put any kind of traction.
Yeah,
Initially, we had
to
surgeons
save one
who
assistant.
did some traction. Now we don't hardly do any traction in the picture.
Yeah, I use it only if I'm doing a combined anterior with posterior, or I'm doing a posterior Bankart.
Perfect. Karthik, you use your GIMS, the scores, which are actually in the instability scores, the new one. The only problem with that is that it has given almost 4 points to an off-track and an on-track lesion, which means if that is there, rest other are immaterial, isn't it?
If you had seen my slides, I had talked about. So this is not an isolated point to consider because it puts all the off-track as Latarjet.
Absolutely.
So, which means we go slowly going to shift to the French perspective to do Latarjet. Also,
using this one, so that came in my mind.
Yes.
Yeah.
Exactly. So I think it's the holistic approach and the factors that we need to consideration.
Exactly.
And there's one small point I would like to add on the Remplissage. I agree with the whole panel's take. The percentage of Remplissage is increasing, but there's that interesting study by Morador et al. Which has showed that all Remplissages do not heal. There is still a subset around 15 to 20% that do not heal, and also there is a complication of resulting partial tear or necrosis of infraspinatus. Yes, it is related to the placement of the knot. So I still believe that we need not inadvertently or arbitrarily push on a procedure that might not be needed and end up in future concept or complication. But I agree that the percentage of Remplissage is on the rise.
Hill-Sachs is something which is a result of a dislocation. It's something which is a fracture, which is sometimes probably giving more attention to Hill-Sachs is also not correct. But yes, as I told you, I think it's more of a capsulolabral injury which has happened.
Yes.
So if you think your capsulolabral complex is not so great, so you actually add on a Hill-Sachs Remplissage in such cases. Yeah, sure. So I don't have any more questions here. My question bank is has been answered.
One question I want to ask about the knotless anchors. The knotless anchors, now there are variations where you have all suture anchors coming with the knotless anchors.
Yeah.
I personally am not used to them, but I wanted the panel's experience on them. You know, how do you find them? Is it being useful?
So I have not used an all suture anchor which is knotless. I use with knots. I think Dr. Usama, you use all suture anchors with knots.
I use
Me
all
too.
suture anchor, the knotted suture anchor, not the knotless one. I know Arthrix, they came with a knotless suture tack, another version which is all suture anchor, the same principle, the Chinese finger trap. I didn't use it till now. Even my all suture anchors are knotted anchors.
I think because it's evolving, probably over a period of time, we would also gain some confidence and maybe we'll start using it. At least our reluctance of, we shifted from titanium to bio to peak and to an all suture. So I think it's an evaluation which probably is going to happen in the life of any instability surgeon as he goes in his practice. So I think...
Dr. Professor Oberoi, you mentioned early about bioabsorbable ones.
Yeah.
I used some in 2009, and I regret using them because it caused me some osteolysis, and I have to revise them. So it wasn't a happy period for me. In 2009, that's why I switched to the beak. For me, beak is having a best of the two worlds, the metal and the bioabsorbable. But yes, the new all suture, it's good because it has a small hole in the bone. You didn't need to drill big holes to get your anchor. As I said, Dr. Osama, I'm still waiting for the knotless all suture to arrive. And it's worth giving it a chance.
Yeah, I think wonderful discussions. Thank you very much. I think Karthik, if you can just conclude and then we can say thank you and good night today.
Thank you to the entire panel. It was an excellent academic feast. I believe the international faculty and beautifully chaired by Dr. I.P.S. Oberoi and also co-chaired by Dr. Thirumalaisamy sir. And personally, I learned a lot. I hope the audience would have also learned something out of the beautiful talks and teaching experiences to all. Thank you one and all for the beautiful talks.
Thank you, friends. And I think it's a dinner time for you guys in Dubai and Emirates. So please enjoy your dinner. And I think good night. And
Thank you very much.
Thank you
Thank
very
you,
much.
Karthik, for
Thank
this
you.
chance to inviting us. It's really great. I will suggest that we also should have the reverse one through Dubai Shoulder course,
Definitely,
which
yes.
we do, and we will be happy to host you, and we exchange our idea about different subjects from time to time.
absolutely.
Thank
The
you,
pleasure
guys.
is ours. The pleasure is ours.
It becomes okay and safe, and probably we would visit sometime.
Inshallah.
Thank you very much.
Thank you.
Thank you.
Thank you.
Every one of you on behalf of Biotek. Thank you so much for being here, and probably we'll see you more frequent on this platform in the future.
Thank you.
Thank you.
Good night.
Thank you so much.
Thank you all.
Have a
Bye-bye.
great weekend. Good night. Thank you.